All right. So that also is related to the issue of access. So we can break down access to healthcare into many different facets. The two that we're going to focus on this unit are can you get there and can you afford it? So the can you afford it piece has to do with insurance and your own financial situation and ability to pay. We're going to talk about insurance more in the next unit. Can you get there? Do you have a vehicle or is there public transportation that can get you there? Do you know how to get there? Do you know where you can go? And is there any place nearby? So one of the media assignments for this unit is talking about the problem of access in rural regions. So that's going to be interesting, I hope, for you to watch. The other thing that I'm going to mention as well when it comes to access to healthcare is, do you feel that you will be welcomed and treated appropriately? So we also see that in groups that have been historically discriminated against and sometimes even still modern day discriminated against do not want to seek healthcare of fear of discrimination or harassment, not necessarily unjustified either. So we often see people of certain racial and ethnic minorities or people who are LGBTQIA don't tend to access healthcare as easily or as readily as other groups where people aren't worried about that problem. So something else to think about. Okay, so now we're doing some additional slides that weren't part of the original lecture because a lot has happened in this region of the state. So just a couple of years ago, just a few years ago, the Mayo Clinic Hospital here in Menominee, as well as in Barron, Wisconsin, closed its labor and delivery unit, closed its birthing unit. The reason for this is they had been trying desperately to recruit OBGYNs to work there with no success. So we've talked before that there's a shortage. There is absolutely a shortage of OBGYNs, especially in rural areas for a lot of reasons. And without the types of physicians that you need to staff it, they just were not able to keep it open. So for a lot of pregnant people now, when they deliver their baby, if they live in this area, they have to go to Eau Claire. That is the closest place. We've also had the closure of two hospitals and many, many clinics in this area. So Prevea, which was run by HSHS, which is actually a religious organization, Sisters of St. Mary Hospital System, Health Sisters. I can't remember exactly how it went, but they ran both Sacred Heart Hospital in Eau Claire and St. Joseph's Hospital in Chippewa Falls, as well as many area clinics. And they announced pretty abruptly, actually, in January of 2024 that they were going to be closing. And by April, all their hospitals were closed and all their clinics were closed almost entirely. So there were people that like had surgeries scheduled and people who had regular doctors that they had been seeing, and all of a sudden everything was gone. So this has had a really huge impact on our community. So Sacred Heart was one of those general hospitals that has a wide variety of services, and the loss to our community has been huge. So why did this happen? So I want to remind you that most hospitals and clinics are nonprofit, not all, but most. So let's take a look at a few important things. So one is that about half of all nonprofit hospitals in the United States are losing money. So this is data from 2022. It always takes time to collate and put this together. And so they found about half in 2022 were losing money. And I want to draw your attention to the median operating margin. So 0.2%, right? So these are nonprofit places. They're not trying to make money, but they need to break even. Look how close, right? And obviously some are doing a lot better and some are doing a lot worse, but like this is not a place where there's like huge profit margins, okay? Or potential, like it's not really profit because they're not profit hospitals. They have to reinvest that money in their services. But anyway, so there's not a lot of wiggle room here. So if we look specifically at Wisconsin hospitals, this is 2021 and 2022 data from the Wisconsin Hospital Association. 2022 is in the darker color compared to 2021. They made the graph kind of strange, so let me get my little highlighter here again. All right, so in 2022, the total margin for Wisconsin hospitals was minus 5%. So they lost 5% on average. Now, so why is this happening? So a big reason for this is increased operating costs. And those fall into two main categories, which are supplies, which includes everything from CT scanners and IV fluids to prescription drugs. So hospitals are dispensing lots of medications to their very sick patients, as well as staff salaries, which we know we've had shortages of healthcare workers. So supply and demand, that drives up salaries. There's also an issue with low reimbursements from public payers and actually also from private health insurance companies, as we'll see. And then there's the issue of uncompensated care. So we're going to take a closer look at some of these. So this is about the cost for drugs and supplies. I'm sorry, it's a really busy slide. There's just so much that I want to share with you. So first, I'm going to draw attention to the graph. And there's two things shown here. One is drug shortages. And so in 2022, 8% of the drugs, right, there was a shortage. So there's problems with supply chains, right? Problems with not enough manufacturers, problems with distribution. And you would think, okay, well, pandemic, supply chain disruptions, right? We should be coming out of that. No. So this is an industry, the drug industry is one where there are significant supply issues. You may know this if you take medications for ADHD. We've been having shortages of those medications for the past year or so now. And so like I have a friend who can't get her prescription and so can't function as well as she should be able to, right? Because there's a shortage. And what's interesting about that shortage is that, I'm going to point, so generic drugs. So these are the drugs that are no longer brand name, so they're much, much cheaper. They are the majority of the medications in shortage, as much as it says 83 of all the shortages are of generic drugs. Now let's think about that, right? Generic drugs are cheap. So there's not as much motivation for a company to build a factory and go through all the things that you have to do to be able to produce that medication if then the return on your investment is going to be low. So we're seeing real issues with a lack of market incentive, really. So economically speaking, in a capitalist system, they're like, why would I go to all the effort of building a factory to make this cheap drug where my profit margin is going to be really low, when instead I could maybe focus on these brand name drugs. And so that brings us to kind of number one. And I know the text is really small. Don't worry, I'm not going to like quiz you on it. But so this is 2023 data. Drug companies continue to introduce new drugs at record prices. So let me just show you. So the median annual price for new drugs, $300,000. So of like new drugs that are coming on the market, it costs $300,000 a year to treat somebody with that medicine, which is an increase of 35% from the prior year, right? So drug companies are just raising and raising and raising and raising the prices, okay? So that is a big problem. Then of course we have the shortages, and then when you have shortages, that drives up prices as well, because everybody, people need their medicine, so everybody's competing to buy that medication. That drives prices up. So again, we can see that in 2023 drug prices overall went up 15%. That's a really significant change. And then hospitals have to try to manage this issue, right? So managing drug shortages and spending pharmacy time trying to call around and see where we can get some, like that also adds additional cost. So drugs and supplies cost a lot, especially in the United States, although there have been some federal government initiatives to rein some of that in, which is very, very promising in terms of both insulin and inhalers for asthma. So there are things afoot that should help, but it's a big problem and we're only just getting going on working to fix it. The other issue is that staffing costs are higher. So no surprise with the healthcare worker shortage and with a general workforce shortage that we're seeing in our state and our nation, in large part due to demographic shifts, and then with healthcare professionals, specifically due to not keeping up with the training programs, and also then burnout and early retirements and people leaving the professions after COVID. Huge increases in hospital employee compensation. So this is looking at 2014 versus 2013, this graph over here on the left. Total hospital employee compensation rate went up by 45%, which significantly outpaced inflation. Here on the right in the purple, you can see from 2018 to 2022, this is from a different organization, on average, staff salaries went from $92 million to $113 million. So that's a big change. And this is going to have a big impact on hospitals' bottom line, because if you look at this graph here, you can see that staffing, payroll, is the biggest chunk of a hospital budget. It's like a school or a university. Like, aside from the building, right, it's the people who are working there that are doing the work, right? You're not selling teddy bears or something, right? So it's the people, it's the services that the people are providing. That was a terrible example, sorry. But okay, so anything that's going to increase the cost of your salaries is going to have a big impact on your overall budget. We also find that for a variety of reasons, public funding is too low. So this is reimbursement from public health insurance. So this would be Medicaid and Medicare. Again, we're going to talk about these more in the next unit. But oftentimes, the amount of money they pay a hospital for the care one of their patients gets is actually less than it cost the hospital to provide the care. So I mentioned earlier that that happens a lot in the outpatient setting. It also happens in the inpatient setting. So this quote here, they're estimating it's about 82 cents on the dollar. So hospitals tend to lose money on especially Medicaid, but then also Medicare patients. Turns out it's not just public health insurance reimbursements that are too low. Private insurance reimbursements are oftentimes too low also, and it seems to be impacting certain aspects of healthcare more than others. So I will tell you, in general, surgical procedures, things like getting your appendix out or having a knee replacement or having your knee scoped or whatever, those things tend to get reimbursed very highly by insurance companies. Even having an endoscopy, right, having them look down, getting a biopsy, those types of procedures tend to be paid pretty well. The types of medicine that require medications and lots of thought on the part of your doctors figuring things out, those don't tend to get reimbursed as well. And so what we're looking at here is on the left, inpatient services, and you can see that overall, right, behavioral health tends to be underpaid at a rate of 34%. So they're losing like 34 cents on the dollar for inpatient mental health treatment. Over here on the right are outpatient treatments. And so you can see, again, behavioral health. So you often don't get reimbursed what it costs you to provide the service. So that's not going to be financially sustainable, right? That's just not going to work. Okay, so now you're starting to see like why these things are happening. So the last thing is uncompensated care. So if somebody doesn't have insurance, or if their insurance doesn't cover something for a variety of reasons, right, hospitals then don't get paid. So a lot of times they will bill the patient, and the patient often can't pay because it's a ridiculous amount of money, and then the patient goes bankrupt and the hospital never gets the money that they're owed, right? Most hospitals cannot control which patients they accept in terms of insurance coverage, right? We have the EMTALA law. We have all types of things. You cannot discriminate against patients in general, especially if they come into your emergency department. And so, especially with these nonprofit general hospitals, right, whatever the patients have in terms of insurance, that's kind of what they're dealing with. They can't say, or they often do not say to patients, I'm sorry, your health insurance won't won't cover you getting this service here, so you're going to have to go somewhere else. Certainly we see that happening more often for elective or planned surgeries where you can do that stuff in advance to figure it out and it's not an emergency, but when you're like sick and in the moment, like that doesn't really happen. Most hospitals are nonprofit. I'm just going to keep reiterating that. And I want to point out the special challenge in rural hospitals. So they tend to have those really low operating margins. Their beds are often empty because they're in small towns and but they still need to have staff there. And so you have expenses without revenue. So rural areas have special troubles with financial instability. So let's look at the issue of uncompensated care. So you can actually find this data. It's publicly available. The link is down at the bottom. And so in Wisconsin overall, if you look at a percent of total revenue, Wisconsin hospitals lost about 1.6%, right, of uncompensated care. So people who weren't paying at all. And then if you look at our local ones, so here's St. Joe's, which closed in Chippewa Falls, and here's Sacred Heart, right? But even here in Menominee, right, they've got a 2% loss just due to uncompensated care, right, in terms of what's costing them money, aside from increased staff costs and all those kinds of other things. So we can see that this is definitely an issue in lots of places. And you might say, it's just 1 or 2%. But remember, the operating margins are usually less than 1% on average. So that 1 or 2% can really make a difference in terms of whether you break even or not. So let's look at how our local hospitals actually did. So this is data from 2022, again, publicly available. So I want to draw your attention to the top line. So Oakleaf Surgical Hospital, that is a corporate for-profit hospital that does surgeries. And as I mentioned, surgeries tend to be paid for really well by insurance, by all types of insurance. How do those levels get set? It's crazy complicated, but surgeries usually get reimbursed quite well. And in fact, at most general hospitals, so Oakleaf Surgical is not a general hospital, they only do surgeries, right? So they're kind of one of those specialty hospitals. They just do surgeries. They don't take care of people with pneumonia and heart attacks and all those types of things. So where was I going? I can't remember. Oh, so at general hospitals, they often try to offset the losses of like taking care of people with pneumonia with the net gains from surgeries. They try to balance it out. So let's see how well they did at our general nonprofit hospitals. So Baldwin doing okay, Barron doing okay, Chippewa, Mayo okay, but look, St. Joe's in Chippewa Falls in 2022 lost $6 million. Marshfield in Eau Claire lost $44 million, right? Eau Claire, Mayo, okay. Sacred Heart lost 21% of their total revenue, $61 million, right? Mayo in Menominee doing quite well, right? So they're a critical access hospital. They do a lot of procedures and they don't have a lot of people in overnight because, you know, they're not a general hospital. They're a critical access hospital. So, right, things kind of balance out a little bit more favorably for them. So now you can start to see why we have those closures, right? It makes sense, especially if you remember behavioral health services particularly are under reimbursed in terms of what they cost the institution. So let's look at this just graphically. Again, you can see the kind of the big losers here in terms of the hospitals that are really in trouble. Sorry, my head is in the way of Menominee, but St. Joe's in Chippewa Falls, Marshfield in Eau Claire, and Sacred Heart in Eau Claire had significant losses as proportion of their net revenue in 2022. So it's not a surprise, right, that they closed. Interestingly, Oakleaf, which is on very sound financial footing, has taken over some of the sites that were closing when Prevea exited. So including the urgent care clinic here in Menominee is now being run by Oakleaf. So that's great to still be able to have that service available in our community. And of course, Oakleaf can kind of afford to do that. Urgent care in general pays usually pretty well in terms of reimbursements, and they don't have, they're luckier in terms of the services they provide tending to be reimbursed better, so they can afford it. Yeah. All right. But obviously, this has had a huge impact on mental health services in our community. So I mentioned that those behavioral health services are often underfunded. Well, it turned out that Sacred Heart had a big chunk of the mental health beds in our community, and it was not meeting the need. So actually in 2021, they got this huge funding. There was a state commission, and they said, we need to improve access to inpatient mental health. And they said, we're going to add on. So the plan in 2021 was that they were going to actually increase the number of adult beds at Sacred Heart and add a whole new adolescent wing in Chippewa Falls at St. Joseph's. And so the total number of inpatient mental health beds through Prevea, HSHS, Sacred Heart, St. Joseph's was going to go from 29 to 51. So when they closed, obviously this never materialized. We never got the increase in beds, and we actually had a significant decrease in beds. So this is what that looks like. So in 2021, which was the last data I could get from this particular resource that you can see at the bottom. So Eau Claire Mayo Clinic Hospital does have 16 inpatient beds. None of them are for adolescents. None of them are for teenagers or children, whereas Sacred Heart had 29, 8 of which were for adolescents. And in Western Wisconsin, which is the region that we are considered part of by the Department of Health Services for the state of Wisconsin, the only other inpatient mental health facilities are Gunderson in La Crosse, which has 30 beds and has some adolescent beds, and then Amory Regional, which has 3 beds. So back in 2021, we had a total of just under 10 beds for every 100,000 people in our population for inpatient mental health. For 2024, now that we've lost those beds from Sacred Heart, assuming there hasn't been an increase in the other beds, and I couldn't quite get that data, and I think there's maybe been a small increase, but it's not enough to replace what we lost. But if we had no increase, that brings us down to only 6 beds per 100,000 people. That is not enough. Let me show you. So this is a psychiatric bed locator. This was a new service started by the Wisconsin Hospital Association just a few years ago to help area providers figure out where they could get an inpatient mental health bed for one of their patients. So what we're looking at here in the top is, well, first, this is for all inpatient mental health hospital beds, adult and adolescent and child. And this is the average available beds per day. And you can see that in October 2024, for this entire region, there was an average of like 4 available. So what that means is if you're having a mental health crisis and you need to be hospitalized, well, then you might have to go to Amory or you might have to go to La Crosse, right? Which is not ideal. The other thing that you can see here is they have number of bed staff per day, and you can see boom, 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 Prevea closes. Right? And now you can see a little bit of recovery. It looks like some places have added some beds or added staffing. So of course, sometimes you have a physical bed in a hospital, but you don't have any nurses to staff it. So that doesn't count, right? You can't actually bring a patient in because you don't have somebody to take care of them. So whether through increased staffing or increasing actual number of beds as well as staffing, there has been a little bit of recovery, but not anywhere near what we used to have. So this is overall. And if we look specifically at adolescent, child and adolescent, so up here is the available beds per day. Look at all of these days where there were 0. So you have a teenager who is acutely suicidal and in crisis. We have no place for them to go. So where do they go? Well, they go to, usually they go to, oh no, I'm having a mental, Winnebago, there we go. Wisconsin State has a inpatient behavioral health facility in Winnebago, which is a long ways away. So imagine you're 14 years old, you're acutely suicidal, and you have to go to Winnebago because that's the only place where there's a bed. And maybe there's not even a bed and they're just going to put you in a hallway. And believe me, that has happened. So not only do you have to go there, but if you're acutely suicidal, you are considered a risk to your own personal safety, right? So the transportation method is by police car. So you're going to be in a police car for 3-4 hours to transport you there to this facility that's outside of your community. There's no opportunity to have family therapy meetings because your family is hours and hours away. And so it's a real problem. This is a real crisis, actually, for our region and for many regions of our state and our country. So just to, again, point it out, I think our region of the state is particularly impacted. So this is looking at the number of inpatient mental health beds per 100,000 population in the different Wisconsin regions as of 2021, which was the most recent data I could find. And then I kind of estimated where we're at for Western Wisconsin. So what you can see, so Western Wisconsin, we were already the least served. We're the least resourced in this area, and now it's gotten even worse. So this is the state average here, statewide of 15.6. So this is a real problem. So it's not only affected mental health services in our area, it also has affected campus health services. So Prevea was actually the provider for the student health services, the student clinic here on campus. And so then there was a kind of a big kind of rush to try to find another provider to come in and provide that, run that clinic for you all as students here on campus. And I don't know how that's going, right? So this new organization just started in the fall of 2024. So hopefully it's going well, but it was a real difficult thing for the university to find an organization that was willing and able to come in and provide that service. So hospital and clinic closures have huge impacts. They obviously have impacts on patient care, right? So when a hospital or clinic closes, then we have decreased access. And this is the access part of this lecture. And I know I've just gone off the rails, but so we have significantly decreased access, and that is bad for patients. People can't get the care when they need it, or it's really delayed, or they try to make do with less than what they actually need. And then it's also bad for families, right? Because then maybe your loved one has to go to a hospital that's hours away. We saw that during the pandemic when hospitals were overloaded then, but we're finding it also now because maybe that's the only place where there's a bed, or maybe because our hospitals that are still here are now so full because the other hospitals closed, they're having to pick up the slack, right? So there's that increased burden on other existing facilities. So I have a friend whose mom fell and broke her foot and got transported to a local general hospital. She was going to need surgery, and they had no place to put her, so she was literally in the ambulance garage for about 4 hours until they actually had a room for her, right? So this just places increased strain on other existing facilities, and it also increases the burden on our public services. So remember I mentioned that teenager that had to go to Winnebago. That's usually a sheriff's deputy that has to drive them. And so then we've got our law enforcement officers whose time is being tied up transporting patients back to and then back from these facilities that are far away. We also see when people can't access the care that they need, that they aren't doing as well as they should. We see increased demand for crisis services. We see increased, distress calls, calls to police for disorderly behavior or disorderly conduct, because sometimes people are having mental health crises. it just places a burden and a strain on our local governmental services. Then, of course, there are impacts on the community more broadly. So when a hospital like this closes, sure, Mayo and Marshfield, if they had any openings for a physician or a nurse, then yeah, those got filled. So that was nice for them in the moment. But there were lots of healthcare providers that left our area because there just aren't a lot of hospitals here. There aren't a lot of clinics here anymore, and they couldn't hire everybody who lost their job through Prevea. And so we lost a lot of people from our community, a lot of highly educated, talented people, not because we don't need those healthcare providers, but just because we didn't have anybody who could actually employ them to work for us. Now, of course, then there's also lots of tradespeople that work for these organizations. These are big buildings. They have HVAC systems. They have electrical systems. We have IT people. We have all types of folks who are working in these industries, so both professional and trades jobs, and then a lot of service and office jobs. So these are major employers in our communities. So we lose those jobs and many of those workers who then relocate elsewhere. And then we also lose the economic activity associated with the hospitals and clinics themselves. So say you're going into town because you have a mammogram or something, then you're like, oh, and then why don't we go out for lunch while we're there? Or we'll stop at the Walmart and the Quick Trip, right? So there's this economic activity that comes along with people coming into your town to access services at the hospital or clinic. And then, of course, when people move out of the area, we lose that economic activity, their local spending, as well as their tax revenue. So that has a negative impact on our community as well. Okay, so now you might be wondering, wait a minute, what about Marshfield? They lost millions and millions of dollars too. Why haven't they closed? And I've got an answer for you. They did suffer significantly financially, such that Fitch, which does all this credit rating system, dropped them down to BBB from BBB plus. And said, the outlook is negative. And in fact, in January 2024, Marshfield furloughed and then later completely laid off 3% of their workforce. And this is after making lots and lots of budget cuts leading up to that, right? You try to hold on to your employees because they are kind of your biggest asset for as long as you can. So what's going on with Marshfield? Why are they not closing? Well, they are merging with Sanford Health. So Sanford Health is a big health clinic system out of Sioux Falls, South Dakota, that is financially very healthy and is very large. And they basically are kind of buying out, they're paying off all of Marshfield's debt. They're basically buying them out and merging with them. And you might say, well, why? If Marshfield has been losing money, why would Sanford want to merge with them? So I just want to show you some numbers here. So look at how big Sanford is, right? So they have 45 hospitals, 211 clinics, almost 3,000 clinicians. So that's physicians, nurse practitioners, and physician assistants, and then 46,000 total employees. They are huge. They are geographically widespread, and they have actually been trying to merge with multiple different organizations over the years. They tried to merge with a health system in Iowa, and that kind of fell through. And then I think even Gunderson, and that didn't work. And then they were going to merge with Fairview in Minnesota, but then there were some current concerns from the state government in terms of labor practices or maybe antitrust, that they were worried about that. So that was not approved by the state government. And so Sanford is looking to grow. Now, then you think, well, what's the advantage? This is risky to take on an organization that's been losing money. Well, remember, one of the ways that these organizations lose money is low reimbursements. Well, the bigger you are, the more bargaining power you have with insurance companies about what rates they have to pay you. So as we start thinking about the systems that we've created and that currently exist, you can start to see why now we're seeing more and more these larger and larger healthcare systems, because then they have some ability to negotiate with the payers, right? As well as all the suppliers, and try to negotiate negotiate for lower prices on supplies and all types of things. So as I mentioned at the beginning of this unit, like we don't have a lot of small practices anymore. The upfront costs are higher, negotiating power is so low, it's not financially feasible in medicine most of the time. So one of the potential solutions for these healthcare systems is just get bigger and bigger and bigger so they get more powerful, so then they can have more say and more control over their costs, which has pros and cons, right? So it's fascinating what is happening. But as somebody who cares about public health and the health of my community, I'm thrilled that Marshfield isn't closing, right? Because we need those providers, we need those services, we need those hospitals. So it's great that they are not closing. So to sum up this kind of long digression into the drama that has been the healthcare organization woes of the Chippewa Valley in the last couple of years, our current system isn't working well in terms of meeting the need of our population. So the economic system that we've created results in financial losses for the organizations that are trying to deliver care, especially if they're doing so in rural areas, especially with certain types of care like behavioral health or general medical care, things that are not surgical, things that are not reimbursed well, or things that have really high supply costs. So one of the things that we need to do, thinking in public health and thinking just as citizens and as folks who vote and as folks who can have agency and talk to our legislators, is think about what changes can we make to the system to ensure access for our populations and to keep our communities healthy.